to speak.
Thank you, sir, for giving me this opportunity. So, posterior segment trauma, most of the posterior segment trauma which we see in our day-to-day life is mostly associated with blunt trauma. And the pathogenesis is either coup, counter coup, or antero-posterior compression. So, posterior segment trauma can manifest in various forms, and we will see each case one by one. So, coming to first case, the commotio retinae. So, it is a manifestation of blunt trauma where after an episode of a lathi stick injury or a cricket ball injury, there is white opacification of the retina. Here you can see the posterior pole, there is white opacification of the retina. And if you do an OCT, you will see the intraretinal hyperreflectivity and thickening of the retinal central macular thickness. And if you do if fluorescein angiography, it will hardly show any leak over the posterior pole. So commotio retinae, it is mainly because of the outer photoreceptor disruption, and generally there is no leakage on fundus fluorescein angiography. So patients have to be counseled that it is generally self-resolving, and if the damage is not that great, then it can slowly cause some vision gain. But one thing is that you have to do a peripheral fundus evaluation, especially the peripheral fundus, to look for any breaks, because blunt trauma are associated with peripheral breaks or dialysis. So choroidal rupture is another condition where there is a crescentic rupture of the choroid, just temporal to the macula or concentric to the disc. It can be focal, single, or multiple. It is generally temporal to the disc, generally in a concentric pattern, and it is generally because of tear of the choroid, Brooks membrane, and the RPE complex. Long-term follow-up is essential for these patients because of the breach of the RP and the choroid. There can be development of choroidal neovascularization, which has to be treated with anti-VEGF injection. So if you see this OCT, this is the choroidal rupture along with subretinal hemorrhage, and if you follow this RP, you can see a focal break in the RP. So this can be a source of choroidal neovascularization later in life. Similar case, you can see a break in the RP over here, which can lead to choroidal neovascularization. So always we have to maintain a close follow-up of this patient for development of choroidal neovascularization. Again, you have to look in the periphery to rule out any retinal breaks or dialysis. And if you have a suspicion for choroidal neovascularization, then you can do an fluorescein angiography to look for leakage. So here you can see the outline of the choroidal neovascular membrane, which is leaking in the later phases, and in the late phase you see the obscuration of the underlying margin. Third most common entity is a traumatic macular hole. So this is again commonly seen after a blunt trauma, after a road traffic accident, patient presenting with a full thickness macular hole. Vision, depending upon the magnitude of injury, it can range from 612 to hand movement. And generally, we must rule out the element of traumatic optic neuropathy also, because this is very important. Because if we counsel the patient for surgery, then if a coincident, accompanying traumatic optic neuropathy is then the vision loss, the vision gain after surgery is very minimal. So always check for RAPD, look at the status of the disc, whether it is pink or whether it is pale. So we have to examine these things before counseling the patients and taking up the patients for surgery. And again look at the periphery, check the aura to rule out any retinal breaks or dialysis. Yes, and again, if the patient is presenting with traumatic retinal breaks or retinal dialysis after a blunt trauma, then that can lead to retinal detachment. In these cases, surely you have to first straight away refer the patient to a vitreoretinal surgeon for further management. So this can take in the form, the retinal detachment, it can have the various forms. So this is a retinal dialysis where retina is disinserted from the aura itself, or there can be a giant retinal tear, or there can be multiple horseshoe-shaped tears in the periphery. Sometimes you can see a brownish band which is straddling across the pupillary area. This is the vitreous base avulsion. So this signifies significant trauma, and again you have to meticulously examine throughout the retina, especially the periphery, to rule out any retinal dialysis or retinal breaks. Another manifestation can be traumatic dislocated lens. So lens can be partially subluxated, or it can dislocate totally into the vitreous and be lying over the retina. Again, you have to straight away, first of all, look for the coincidental other signs of injury, like increased intraocular pressure, subconjunctival hemorrhage. It can accompany occult rupture also. So before taking up the patient, you just inspect the overlying sclera whether there is occult rupture or not. Look for vitreous in AC. A deep anterior chamber signifies a dislocated or subluxated lens. There could be a coexistent iris sphincter tear and retinal break. So in these cases, patients have to be referred to the vitreoretinal surgeon for taking up the patient for pars plana vitrectomy, lensectomy, and scleral fixated IOL. Another case is Terson syndrome, which is generally seen after a blunt trauma, especially in road traffic accident, where patients present with intraocular hemorrhage and also intracranial hemorrhage. So this can manifest either in the form of subarachnoid or subdural hemorrhage. So this is one case which we saw. One of the nursing staff, he presented after a road traffic accident. He presented with a subhyaloid hemorrhage over the macula. So on the CT scan showed a subdural hematoma. So we took up the patient and we did, this is the OCT. There is a detached overlying posterior hyaloid and a subhyaloid hemorrhage. So we did a YAG hyalotomy, which drained out this blood, and finally this blood was cleared out. So whenever a patient is presenting with subhyaloid hemorrhage after a road traffic accident or a blunt trauma, always we have to take a history whether he was unconscious or whether there was a lucid interval, and if there are suspicion, then do get a CT scan done, because this can reveal underlying subdural hematoma, which can be lead to a neurosurgical intervention also. So sometimes, very rarely do we come across non-occidental trauma in a form of in infants in a form of shaken baby syndrome, and this is generally seen in first-time parents, mostly male, who are either suffering from depression, where they repeatedly hurt their infants, their child, and there can be a triad of subdural hematoma, subarachnoid hemorrhage, and retinal hemorrhage. So this can manifest in the form of hemorrhages in all the retinal, either in the preretinal hemorrhage or in the intraretinal or subretinal hemorrhage. Hemorrhages of varying ages, some will be fresh, some will be old, which can accompany an intracerebral hemorrhage, and it is either because of repeated abuse of the infants. And this can also accompany other external signs also accompanied with ledecymosis, conjunctival tear, hyphema, or corneal laceration. So basically here the problem is with the parents rather than with the children. So first of all, counseling to the parents, and again attending the subsequent injuries among the infants, which we have to do. So, and now in this case of war, sometimes we come across a traumatic chorioretinal rupture, which is secondary to a high-speed missile injury. So actually, this is a case of coup injury where a missile grazes a part of the temporal part of the eyeball, and all the shear stress and all the shock waves are suffered, causes damage of the temporal part of the retina. So here we see. So here you can see here the temporal part of the retina, it is totally sheared out, leading to loss of the retina and choroid, and lying bare of the sclera, which is totally bare. So here also just we have to do a meticulous follow-up for development of for management of any complications which can happen later in life, like neovascularization or retinal detachment. So one case which I would like to share, which is generally seen after a road traffic accident, especially after fracture of long bones, or in case of acute pancreatitis, is a case of posterior retinopathy, where patients can present with multiple retinal opacification throughout the fundus. So this is basically because of either long bone fracture and chest compression injuries, or it can be seen in area or amniotic fluid embolization.
Dr. ABHISHEK, please summarize. We are running out of time.
So to conclude, all general ophthalmologists, they should be familiar with the posterior segment manifestation of trauma, because timely evaluation and thorough evaluation is very critical, and they should be aware of the potential and late complications which can happen in each case. So